afternoon, we are a medical team of podiatrists that will be looking at lower limb overuse injuries, where we will be exploring the link between hallux adductor valgus and high heel use in females. We used a 5-step approach to evaluate and outline the risk factors involved in our pathology HAV. We developed a question to extract the required evidence to make a recommendation to our sporting club. So the population was females, our measurement was high heel use in females, and our outcome was HAV. Therefore, our question is, are females that wear high heels at a higher risk of developing hallux adductor valgus than those that do not?
HAV is a triplanar forefoot deformity, most commonly characterised by the lateral deviation of the hallux at the MTPJ across the transverse plane. HAV generally leads to the development of a bursa and exostosis at the medial aspect of the first MTPJ. Abduction of the hallux is normal in forefoot mobility, however deviation greater than 15 degrees is considered to be HAV. There are various etiologies and predisposing factors which lead to the development of HAV. Extrinsic contributing factors include inflammatory joint disease, connective tissue disorders, systemic pathologies characterized by generalized ligamentous and neuromuscular diseases characterized by the development of pes cavus and pes plano foot types. Intrinsic predisposing factors include trauma, structural anomalies, genetics, and biomechanical factors of the rear, mid, and forefoot. Contrary to popular belief, studies have shown that HAV is not primarily caused by unsuitable footwear, such as high heels or tight, narrow toe box. Rather, the unsuitable footwear exacerbates the forefoot pathologies associated with existing HAV. Biomechanical factors characterized by excessive and compensatory pronation affect the rear foot, including STJ and MTJ, where the foot remains in pronation from mid-stance through to toe-off, can lead to the development of HAV. This includes ankle equinus, flexible or rigid pes plano valgus. Ankle equinus occurs in the sagittal plane, involving the limited dorsiflexion at the ankle joint when the STJ is in neutral position. Ankle equinus can be caused by a variety of reasons, such as osseous and muscular deformities. Most commonly, ankle equinus is caused by tight gastrocs, soleus, and Achilles tendon, limiting the range of dorsiflexion at the ankle, which can be linked with high heel shoes. Ultimately, this can lead to HAV due to compensation made during gait. Fran and Neal state a minimum of 10 degrees of dorsiflexion is needed at the STJ. If the ankle joint does not achieve 10 degrees of dorsiflexion during mid-stance, the foot consequently compensates through STJ and MTJ pronation. Prolonged pronation with no supination or very late STJ supination means the foot does not form a rigid lever. This compensation of pronation and hypermobility leads to the development of HAV, causing lateral deviation of the hallux and medial deviation of the first metatarsal. Structural anomalies with the lower limb that also predispose to compensatory excessive foot pronation include external tibial torsion, tibial varum, positional variance of the knee, wide base gait, and leg length discrepancy. These structural anomalies affect the biomechanics of the rear foot, causing excessive pronation during the gait cycle, emphasizing lateral deviation of the hallux and medial deviation of the metatarsal during mid-stance and toe-off, leading to HAV. In common, these rear foot biomechanical discrepancies lead to prolonged pronation and a minimal supination of the STJ and MTJ during mid-stance to toe-off. STJ pronation increases range of motion at the MTJ and unlocks the foot, making it less stable during the propulsion phase of gait. Consequently, this causes lateral displacement of the hallux and medial deviation of the first metatarsal due to the ground reaction forces. Inversion of the metatarsal results in stretching of the tibial sesamoid ligament, causing intersesamoidal ridge to erode. HAV is a multifactorial etiology as described above. According to the systematic review by Nick, Smith and Vincenzo in 2010, estimates HAV prevalence to be 23% in adults aged 18 to 65 years and 35.7% in elderly people aged over 65 years. Prevalence increases with age and was high in females compared to males. While HAV is not caused by high heels and a narrow toe box, the existing deformity can be exacerbated through the use of ill-fitted footwear. Elevation of the high heel can cause tight gastrocs, resulting in the tight Achilles tendon, which results in overloading the first ray, exacerbating the HAV deformity. Another theory relating to high heels suggests that the heel elevation may cause the wearer to roll off the medial aspect of the hallux when walking rather than propelling themselves directly forwards.
To complete this inquiry, we were guided to accurately identify the level of evidence of two studies using the National Health and Medical Research Council evidence hierarchy. The first article I appraised was titled Footwear Characteristics and Foot Problems in Older People, written by Menz and Morris in 2005. The objective of the study was to examine the relationship between footwear characteristics and the prevalence of common forefoot problems in older people. The study sample was a group of 176 people suffering from foot pain and assessed their past and present footwear by undertaking a questionnaire and clinical assessment to try and uncover whether their choice of footwear was the cause of their symptoms. This would make the study a retrospective cohort study, as it is looking back at events that have already taken place and trying to determine the cause or etiology, so it is classified as a level 3-2 on the NHMRC evidence hierarchy. The second article appraised was titled Factors Associated with Hallux Valgus in a Population-Based Study of Older Women and Men, the Mobilized Boston Study by Nguyen et al. In 2010. The objective was to examine the potential risk factors for HIV in community-dwelling elders in Boston, USA. There were 600 participants involved in the first wave of this ongoing longitudinal study who were analysed as having hallux valgus greater than 15 degrees angular deviation of the first metatarsal bone toward the lesser toes. This is described as a prospective cohort study due to having a study sample and following their progress over a set length of time. This is classified as being a level 2 on the NHMRC evidence hierarchy with respect to etiology and causal factors of the condition.
In the study conducted by Menz and Morris 2005, prevalence of ill-fitting footwear seen 23 test subjects wear indoor shoes that were too short for their feet, 136 test subjects wear indoor shoes that were too narrow for their feet, and 73 test subjects wear indoor shoes that had a smaller total area compared to their feet. Table 2 on the left shows that the percentage difference between foot and shoe dimensions for indoor and outdoor shoes according to gender. Women exhibited a greater disparity between shoe and foot dimensions with respect to indoor shoe length, width and area compared to men, as well as outdoor shoe length, width and area. All categories demonstrating strong evidence with a statistically significant p-value of less than 0.001. As you can see from Table 3 on the right, prevalence of foot conditions shown women were more likely to have corns, calluses, hallux valgus, lesser toe deformity, and foot pain compared to men. 3 out of the 5 categories had a p-value of less than 0.01, whilst the other 2 categories had a p-value of less than 0.05, demonstrating strong evidence. Shown in Table 4 are the odds ratios and 95% confidence limits for the associations between the presence of foot problems and the upper quartile of ill-fitting footwear. As you can see, the presence of corns was associated with adequate width and area of both indoor and outdoor shoes. Calluses were associated with adequate width of both indoor and outdoor shoes. Moderate to severe hallux valgus was associated with an adequate width and area of outdoor shoes and inadequate width of indoor shoes. Lesser toe deformity was associated with an adequate length of both shoe types, and foot pain was associated with an adequate width of indoor shoes. Once gender was entered into the logistic regression equation as an independent variable, all foot problems apart from calluses demonstrated the same statistical significance. Due to calluses were not associated with any footwear fitting variables after adjusting for gender. With respect to heel elevation and foot problems in women, 26 women wore outdoor shoes that had a heel elevation greater than 25 millimeters. Heel elevation was significantly associated with hallux valgus and calluses, with each foot problem demonstrating a p-value of less than 0.05 and 0.01 respectively. However, a past history of wearing high heels did not show any association with foot problems. In relation to the study conducted by Nguyen et al. 2010, Table 1 demonstrates the distribution of the study characteristics for 386 women and 214 men. As you can see, over half the women had hallux valgus, and the prevalence was more than twice as high in women than men. The age distribution for women and men was similar, however slightly more women than men were obese. Also, women had a slightly higher prevalence of foot pain and pes planus than men. Among women, the proportion who wore high-heeled shoes as their usual shoe type during ages 20 to 64 was slightly less than 25%. The association of hallux valgus with BMI, foot pain, and pes planus were significantly different between the women and men. Formal tests of these risk factors with regards to sex revealed significant interactions between the overweight and obese BMI groups, both demonstrating strong evidence with a p-value of 0.003 and 0.02 respectively. In addition, interactions were found between sex and presence of foot pain as well as pes planus, 0.03 and 0.04 respectively. Figure 1 presents the association of hallux valgus across 3 categories of past high heel use. As you can see, in the last category, women who reported wearing high-heeled shoes as their usual shoe type of footwear for the entire period between the ages of 20 to 64 had a 20% increased likelihood of having hallux valgus compared to women who did not.
In the best interest of women that wear high heels, we had to decide if the use of screening measures would prevent the occurrence of hallux valgus. If so, the cost associated with treating this injury may be minimised by prevention strategies. When deciding to apply the evidence from Menz and Nguyen, we were aiming for a strong grading category, as per the recommendation table modified by Van Tilde and colleagues. The screenings to determine risk factors could only be included absolutely if consistent findings were displayed from at least 2 high-quality cohort studies. We explored the both articles that were shown to demonstrate cohort studies of the retrospective and prospective type, respectively. Therefore, according to Van Tilde, the resulting evidence can be considered strong in assisting our decision to apply it. Menz and Nguyen displayed findings that were related to the women with hallux valgus that included ill-fitting footwear such as shoe type and width, being of female gender, pes planus, and foot pain. Nguyen found the risk factor that displayed the strongest association with hallux valgus to be high heel use. Therefore, when applying the findings to women with the pathology of hallux valgus, these issues should all be considered as potential risk factors, especially the use of high heels. In conclusion, we recommend it is in the women's best interest to be screened for the numerous risks of hallux valgus. Screening measures in conjunction with an intervention program will benefit those women who wear ill-fitting footwear such as high heels. Prevention of this major risk factor will not only minimise the cost of treatment, but will also reduce the time required for management. We believe if successfully applied, the use of conservative and preventative approach will significantly decrease the risk of developing hallux valgus.